Okay. First of all, I'm very sorry for my slides. I'm not actually prepared with my slides. I have some PDF format. I've just converted to PPT. So I don't think you people are comfortable with my slides, but whatever, I try to explain orally rather than in slides.
Okay.
Okay. So today's topic for discussion is thyroid and prolactin. So I think most of us know that the thyroid issues will lead to infertility. And after correcting thyroid disease, infertility usually it doesn't interfere much. So today, the main concept of this class, what I want you to know is what's the role of subclinical hypothyroidism, when to start treatment even if the thyroid levels are within normal limits, that is in the subclinical range also, whether what does studies say whether to start treatment even when TSH is below 5, even when the TSH is around 2.5. So is there any difference if the patient comes with infertility or if the patient comes with pregnancy? Is there any guidelines? Are the guidelines any different from normal non-pregnant or non-fertility patients? We'll see that. We'll also see a brief about how prolactin interferes with fertility, what all it causes with ovulation, what all it causes with spermatogenesis, how it interferes, how are we going to evaluate the patient, and what's the treatment options for hyperprolactinemia in infertility. So I will not take more than 15 minutes, I guess. So in this, I'm not going more in depth into theory. Also, I just want to clarify few practical issues. So my slides, I accept that they are not clear. I'm sorry for once again for my slides. So thyroid and infertility, endocrine and immunological factors play a significant role in reproduction. Assisted reproductive technology has led a tremendous changes in the perspective of infertility. How does it affect female thyroid problems? How does it affect male? In female, it causes hypothyroidism. Always leads to hyperprolactinemia. They go hand in hand. So thyroid abnormalities may increase the prolactin level. They causes delay in onset of puberty with anovulatory cycles. They might cause recurrent miscarriages, or they might lead to amenorrhea. They might lead to, along with prolactin abnormalities, it might lead to galactorrhea. They increases overall, they increases the incidency of infertility, and also PCOD is also a bit related to the hypothyroidism also. In males, they increases the estrogen production, they interferes with spermatogenesis, they cause hypothyroidism in males, may lead to low sperm count and sperm motility issues also. They actually have more effect on every cell in the body. They have profound, they interfere with estrogen and androgen metabolism, they causes menstrual function abnormalities and all fertility issues. Mm, so, what is the difference between overt hypothyroidism and subclinical hypothyroidism? In overt hypothyroidism, na, what is overt hypothyroidism? Elevated serum TSH and low T4 with symptomatic thyroid hormone deficiency. This is the definition of overt hypothyroidism. What is subclinical hypothyroidism? In this, there is TSH is elevated, but T4 is normal. Biochemical thyroid hormone deficiency is there. So the difference between overt and subclinical is that TSH is elevated in both. T4 is normal in subclinical hypothyroidism, but in overt hypothyroidism, T4 is low. So subclinical hypothyroidism is usually seen around, the incidence is around 0.5 to 40%, it might see. So one third of all subfertility patients have thyroid issues, and over 50 to 70% of hypothyroid patients have menstrual irregularities also. And 46% of infertile patients with hypothyroidism have hyperprolactinemia, and 10% have inadequate corpus luteum and luteal phase defects also. So how to go about with evaluation? So how does it causes menstrual? So I'll just tell you how does it cause menstrual abnormalities. So hypothyroidism, actually it has it may interfere with hemostasis mechanism also. It causes, and it interferes with estrogen metabolism also. It alters the peripheral estrogen mechanism. It causes disturbance in GnRH secretion, and abnormal pulsatile release of LH is seen in hypothyroid patients. And high titers of TRH and hyperprolactinemia, along with hyperprolactinemia, also it causes menstrual dysfunctions and hypothyroidism. As such, it increases the ovarian volume and stromal volume also. So all these might lead to ovulatory disturbance and leads to menstrual abnormalities. So coming to how to evaluate the patient. So whenever what is this slide showing? Elevated TSH, check T4. If the T4 is decreased, this is overt hypothyroidism. If the T4 is normal, that is subclinical hypothyroidism. So thyroid disorders are categorized into three categories: hypothyroidism, overt, subclinical. Um, the prevalence of overt and subclinical hypothyroidism in general population is 0.3 to 0.4%, and subclinical, as I've already discussed, is around 4.3 to 8.5% respectively. So most common cause is iodine deficiency and chronic autoimmune thyroiditis in iodine depleted areas. In hypothyroidism, the hormonal changes occur in, and I have already told you. So, overt subclinical, I have discussed menstrual disorders, how it leads to menorrhagia, and all I have discussed. So, cause of infertility due to hypothyroidism includes anovulatory cycles, defects in luteal phase, hyperprolactinemia. It affects release of GnRH pulsatile secretions. In males, it decreases the sex hormone binding globulin, it decreases the testosterone, it decreases libido and erectile dysfunctions. So anti-TPO antibodies should be always checked. If repeated TSH levels is more than 2.5 and history of recurrent miscarriages, anti-TPO antibodies should be checked mandatorily. So levothyroxine is the treatment of choice in hypothyroidism, and the dose of levofloxacin is between 25 micrograms to 75 micrograms if TSH is less than 10. That is overall 1.6 micrograms per kg body weight if TSH is more than 10. So if TSH is more than 10, then we should calculate like 1.6 micrograms per kg body weight. If TSH is less than 10, the dose should be between 25 to 75. The normal range of TSH should be maintained around 0.5 to 2.5 micro international units per ml. Total T3, T4 should be monitored. Total T3 and free T4 should be monitored 2 to 6 weeks after starting antithyroid drugs. Hyperthyroidism and male infertility. It causes hyperthyroidism, it causes erectile dysfunctions, and also low sperm counts and abnormal progressive motility. Impact on male infertility, hypo and hyper. Hypo, it causes morphological abnormalities of sperms and erectile dysfunctions. In hyperthyroidism, mainly it affects the motility. It decreases sex hormone binding globulin, and thereby decreases testosterone, and thereby libido is lost. So these antibodies interfere with folliculogenesis, spermatogenesis, fertilization, and embryo formation also. Women with Graves' disease demonstrate positive TSH receptor stimulation antibodies and diffuse uptake of radioactive iodine. These women should be treated along with an endocrinologist. Treatment options should include radioactive iodine, antithyroid drugs, and thyroidectomy. In women receiving radioactive iodine, pregnancy should be planned after 6 months. Just give me a minute. This is missing. This this flowchart is missing. What does that flowchart tell is that in cases of infertility, if the patient is overt hypothyroidism, you have to treat it. If it is subclinical hypothyroidism, if the patient is coming with infertility issues, or if the patient is pregnant, we have to treat it. Or if the patient is anti-TPO antibody positive, we have to treat it. If the patient is not pregnant, if the patient is not anti-TPO antibody positive, if the patient has no infertility issues, there is no need to treat subclinical hypothyroidism. If it is euthyroid, then no need to in case of euthyroid, if there is anti-TPO antibody positive, you have done for some other causes and she's like positive for anti-TPO antibodies, then whether to treat her or not is a big question, because thyroid is in normal limits and anti-TPO antibodies are there. So what literature says is that even if the patient is euthyroid, the patient has anti-TPO antibody positive, if the patient has history of recurrent miscarriages, or the patient is undergoing an IVF treatment, then you have to treat with 25 micrograms of L-troxin. So this is altogether a new concept, which this actually this flow chart is showing, which is almost cut. I don't think your people are able to see the flow chart. I think you can see it. Wait, I will. Yeah. In case of infertility, the patient is overt hypothyroid, we have to treat it. In case of subclinical hypothyroidism, the patient is coming in with infertility, we have to treat it. So if the patient is euthyroid and she is anti-TPO negative, there is no need of treatment. If the patient is euthyroid and patient is anti-TPO antibody positive, if the patient is planning for IVF or is a case of recurrent miscarriages, you have to treat her. If the patient is not planning IVF or is she is not a case of recurrent miscarriages, there is no need to treat it. This whole concept is new, so I would just want you to make a note of it. If the patient is coming for infertility, if your infertile patient is having subclinical hypothyroidism, you have to treat it. If she is euthyroid and you have done anti-TPO antibody, if it is positive, even if the thyroid level is normal, because she is planning for IVF, if she is going, if you are doing IUI cycles or OAT cycles, there is no need of treatment. But if she is planning for IVF, then you have to treat it. Or if she is a case of recurrent pregnancy losses, or in that patient you are doing OATI cycles or IUI, also you have to treat the patient. So now next question comes: what is the dose of the treatment? The dose of the what is the dose of thyroid? So we have to give 25 micrograms of L-troxin. So this is the new concept and important concept. I want you all people to have a note of it. So coming to prolactin and infertility. Prolactin is produced by anterior pituitary gland and mainly involves with lactation. Hyperprolactinemia is common endocrine disorder with gonadal dysfunction. It might present with amenorrhea, oligomenorrhea, galactorrhea, and infertility. It pres, High prolactin, it decreases implantation, it causes decreased GnRH production, it might affect granulosa cell, it causes granulosa cell dysfunction, it inhibits corpus luteum leading to luteal phase defects, it has effect of it might lead to endometrial dysfunction. So it increases the implantation potential of the endometrium also. So how it prolactin plays a role in oocyte maturity and capacity of it to get fertilized. It causes early corpus luteal form. It plays a role in corpus luteal formation and survival. It causes improvement in blastocyst implantation potential, embryo endometrial synchrony. It has a role. It causes pro-survival factors for low motile sperms and involvement in desocialization. So the inhibition of hypothalamic secretion of GnRH involves metastasis suppressor kispectin 1 neurons that expresses prolactin receptors through which prolactin may exert its inhibitory effects at this level with downstream disruption of GnRH secretions. The central role of kispectin 1 in mediating the prolactin action on GnRH secretion is highlighted by the restoration of fertility by kispeptin 1 administration. Prolactinomas is classified as if the prolactin levels are more than 250 and less likely when levels are less than. Prolactinomas, the patient might be having prolactinomas if the prolactin level is more than 250, and less likely if the prolactin levels are less than 100. So microprolactinoma, that is the tumor is less than 1 centimeter in diameter. Macroprolactinoma, when the tumor is more than 1 centimeter in diameter. 60% of the men presents with macroprolactinomas and 90% of females presents with microprolactinomas. That is, microprolactinomas are more common in females and macroprolactinomas are more common in men. So, approach to the diagnosis of hyperprolactinemia. I don't think this is that clear for you. So, raised prolactin, rule out other causes of rule out other hormonal defects also. So rule out any other drugs which causes hyperprolactinemia, like certain antacids, anti-hypertensive drugs might leads to emetic drugs might also leads to hyperprolactinemia. So rule out the patient is taking any of these. So if the patient is taking some other drugs, ask the patient to stop it and again recheck the prolactin. Even if in that case, if the prolactin is elevated, then do MRI. If the MRI is normal and the patient is, if the MRI is normal and patient is asymptomatic, there is no need to treat the patient. If the MRI is having microadenoma and the patient is asymptomatic, there is no need to treat. If the patient is symptomatic, if, then treat it with like drugs. If the patient has macroprolactinoma, then surgery is mandatory. So this flow chart. So objective of treatment with hyperprolactinemia. Objective of treatment is restoration and maintenance of normal gonadal functions, restoration of normal fertility, prevention of osteoporosis. If the pituitary tumor is present, then correction of any visual or neurological abnormalities if there, reduction or removal of tumor mass, preservation of normal pituitary function, and prevention of progress of pituitary and hypothalamic diseases. See how to approach and manage hyperprolactinemias if the in MRI. If the MRI is normal and patient is symptomatic, and if the MRI has microadenoma and patient is symptomatic, in asymptomatic there is no need to treat at all. If the patient is symptomatic, then give dopamine agonist therapy. If the prolactin levels are normal, then just follow it up every 4 to 6 months. If the if after treatment the prolactin level reduced and the patient is asymptomatic, just measure prolactin levels every 4 to 6 months. But even if you are giving the drug and even though the prolactin levels have decreased, but the patient is symptomatic, even the levels are normal, then consider pituitary surgery. In case of if the prolactin levels are not subsiding even after 6 months of treatment, then plan for surgery. So you are planning for surgery in case of microadenoma only, even only in cases where you are giving the treatment and the prolactin levels are not subsiding even after 6 months of treatment, or the patient, even if they are subsided but the patient is symptomatic. In those cases, you are planning for surgery. Otherwise, you are just giving drugs and monitoring the prolactin levels every 4 to 6 months. In case of macroprolactinemia, measure measure other hormones, measure other pituitary hormones also. So excluding, is there any other deficiencies or is there any other hormonal abnormalities, just check them also. Isolated prolactin, if there is no other abnormalities, only prolactin is abnormal, then give dopamine agonist therapy. If the levels are normalized, then measure it every 4 to 6 months. If the levels are not, if the levels have reduced and the patient is this is also same, the levels have decreased but the patient is symptomatic, or the levels are not at all subsiding, then in that case, then go for surgery. in case where there is a stock effect, that is prolactin level is not high enough for the size of the tumor, that is the size of the tumor is big and the prolactin levels are not that great to give you dopamine therapy, then in that case do directly pituitary tumor. So what's the whole concept of this is that if the patient is hyperprolactinemia and she is asymptomatic, then there is no need of treatment at all. If the patient is having high prolactin and the patient is symptomatic, do prolactin levels. If the prolactin level is more than 250, there is more high likely the patient is having prolactinomas, whether it can be micro or macro. If it is less than 100, then there is less chances of patient having prolactinomas. Prolactinomas, there are two types, micro and macro. Micro more common in females, macro more common in males. So in case of microprolactinemia, if you are doing MRI, if the patient is in case of if the MRI is not, in case of hyperprolactinemia you are doing MRI, if the MRI is normal or MRI is having microprolactinemia and the patient is asymptomatic, there is no need of treatment. If the patient is symptomatic, then you dopamine agonist. If the levels decrease, then there is no, then you just need to follow up the patient every 4 to 6 months. If the level has decreased or if the level has not decreased and the patient is symptomatic, then go for surgery. In case of macroprolactinemias, do other hormonal evaluation also. If check whether which hormones are deficiency, which thing is deficiency. If in case only prolactin is high, in that case give treatment. If it is subsided, if the prolactin has come to normal, just follow up the patient every 4 to 6 months. If the prolactin has not norm, it is decreased but still the patient is asymptomatic or the prolactin levels are not at all getting decreased, then it is an indication for surgery. Or if the prolactin levels are normal and there is a high tumor size is big, then it's an indication for surgery. So what are the drugs? We are having bromocriptine and cabergoline. Both are dopamine D2 receptor agonists. So the T half is more in for cabergoline, that is 65 hours, so that you can take weekly once or twice. For bromocriptine, you have the dose is 2.5 to 10 milligrams in divided dose per day. Both are category B, but we tend to more give cabergoline because the compliance is better. Indications of pituitary surgery, we have already discussed. Intolerance to medical treatment considered in patients the tumor for whom long-term treatment is not acceptable. Surgical decompression may be required for tumors pressing on the optic chiasma. Surgery should be avoided in cases of extracellular without optic chiasma compression, expanded tumors because of low success rates. Follow-up, I think we have already discussed this one. So, first of all, I'm sorry the slides are not great. Secondly, I just wanted you to know that to know the concept of hypothyroidism and euthyroid and infertility. So we all know hypothyroidism and hyperprolactinemia causes infertility. How it causes infertility? It affects with folliculogenesis. It affects with it causes hormonal abnormalities. It is involved in estrogen metabolism also. It is involved in product spermatogenesis. It involves sperm production, libido, testosterone levels. It causes sperm production abnormality. It causes motility issues also, erectile dysfunctions also. So we need to treat hypothyroidism. We need to treat hyperprolactinemia. So in hypothyroidism, yes, how to treat it? If it is high thyroid levels, or if TSH is less than 10, then 25 to 75 in between. If the TSH is more than 10, then 1.6 micrograms per kg body weight. So if the TSH is normal, but the patient is coming for you, TSH and T4 is also normal, but the patient is coming for you for IVF treatment, or the patient is having a history of recurrent miscarriages and anti-TPO antibodies is positive. In that case, you need to treat the patient with 25 micrograms of L-toxin, even in case her TSH and T4 is normal also. This is the new concept, which is usually confusing but I want you to have clarity with this concept. In case of hyperprolactinemia, yes, it also involves in folliculogenesis. It involves with blastocyst formation. It is involved with implantation issues. It causes implantation failure also if it's not corrected. So it also involves in all steps of fertilization to in all steps of reproductive this thing. So how to evaluate it? We all like prolactin levels. What's the level of prolactin? If it is more than 250, more chance of any tumor is there. If it is less than 100, less chance if the patient is having any tumor. So if there is hyperprolactinemia, then do check if the patient is having any using any drugs. If she is not using any drugs, then repeat the prolactin levels. Or if the patient is using any drugs, then ask her to stop all those provocative drugs and repeat the prolactin levels. If it is high, then do MRI. If the patient is asymptomatic, no need to treat. If the patient is symptomatic and she is having microadenoma, then give drugs. If the prolactin levels subsided, then just do follow up every 4 to 6 months. If the prolactin levels did not subside or it did not reduce, or the patient reduced but patient is still symptomatic, then plan for surgery. In case of macroadenoma, rule out other hormonal issues also. If there is nothing, if only prolactin is elevated, then see if it is very big tumor, you anyways need to do surgery. If it is not that big tumor, if you dopamine agonist drug there also. So with drugs, if the TSH is subsided, if the prolactin is subsided, then just to follow. If it is not, if it is subsided but the patient is still symptomatic, or if it's not subsiding, then plan for surgery. So this is the whole gist of the topic. So people having any doubts can ask me. Otherwise, we'll end the session.
So, ma'am, normal level of thyroids is to maintain people who are trying for fertility is from 0.5 to 2.5.
Yes, 0.5 to 2 point. Actually, they give 0.3 to 2.5.
Okay. Okay. So then, according to the body weight, if it is falling above 2.5, it is above.
No. If it is between 2.5 to 10, then you need to adjust between 25 to 75. If it is more than 10, TSH is more than 10 only, you need to give according to the body weight, 1.6. Yes.
Okay.
1.6 microgram per kg body weight. Because if the TSH is 5 and you started giving 1.5, then you need to give so much, 80 micrograms you need to give. So that is too high dose, no? So only if the TSH is more than 10, you need to go according with the body weight. Otherwise, you can titrate the dose between from 25 to 75, depending upon the TSH levels and depending upon the body weight of the patient, BMI of the patient.
And in hyperprolactinemia also, parallelly when the patient is being treated, if she has no microadenoma or macroadenoma, but the levels are high, like 100 and all. So the dopamine agonists have to be given, and parallelly we can try for infertility treatment, madam.
Yes. Actually, what's that? If in case of hyperprolactinemia, always check thyroid abnormalities because they both go hand in hand. If you are treating thyroid disease abnormalities, now hyperprolactinemia subsides automatically. Yes, if it's not going, see if she's using on any drugs, or actually if prolactin levels depends upon the time of the day when it is collected, or if the patient is too anxious at the time of taking the sample also, the prolactin levels usually comes high. So whenever there is hyperprolactinemia, do check other fasting sample, and patient make sure the patient is relaxed at the time of sample collection also. So even if even in that case also, even after repeated doing investigation also, if it's high, then plan for MRI or treat the patient.
Okay.
So I just want you all people to know the concept of anti-TPO antibodies and euthyroid. That's the only different thing I have told you. I have clarified you, which is the important concept. Otherwise, I think you all find all this, what all I told you, find it in books also very easily. and most of you know it also. But what I want you all to know it is, even the patient is euthyroid and anti-TPO antibody positive, if the patient is having coming for IVF or having history of recurrent miscarriages, then you need to treat the patient. That's the only different concept I have told you in today's class, I think. Otherwise, everything else you people know it already. And everything else is theory, which we usually get in any other book.
Okay, ma'am. Like only in those scenarios where the patient is not getting conceived or going for advanced treatment, or the patient is having recurrent miscarriages with normal thyroid, should we be
If the
doing?
patient is having anti-TPO antibody positive only.
I mean, with the normal thyroid, euthyroid, usually doing anti-TPO is very rare. But when
Yeah,
we
rare,
have
but nowadays, these
scenarios,
days, everyone is doing, everyone, yeah, I know it. But these days, with history of recurrent miscarriages, we are doing anti-TPO
hmm.
antibodies, right?
Okay, yes,
That's,
ma'am. That in those scenarios
yeah.
we will be doing, and if a patient is trying continuously, even with the normal, everything is normal, like unexplained infertility and all. Even there, we can be doing like this, as
Yeah,
you told, ATPO antibodies. So if we find it positive, we can start with 25 mics of
25
thyroid.
micrograms. Yes.
Yeah. Yes. Thank you.
Hmm. Okay, then, shall we call it a day? Shall we end the session?
Yes.
Thank you, girls.
Thank you.
Thank you.